Hello everyone, welcome to this session for this week's lesson. So for this session, we're going to talk about the disorders of the hypothalamus and the pituitary gland. And again, I'm Dr. Ana Angelica Macalalag-Josue. I'm an internist and an endocrinologist. So for today's session, these are our learning objectives. At the end of this lecture, you guys should be able to review the anatomy, development, and physiology of the pituitary gland, describe the synthesis, secretion, and action of the different anterior and posterior pituitary hormones. Next, we're going to illustrate the approach to patients with hyperprolactinemia and prolactinoma. And then we're going to briefly identify and diagnose patients with disorders of growth and development. And also at the end of this lecture, you guys should be able to organize the various etiologies of hypopituitarism. And one example that we will use will be Kalman syndrome. And again, also you guys should be able to apply the approach to a patient presenting with a cellular mass. So we will have a case, a mini case discussion for this. And then I want you also guys to be able to demonstrate how to work up a patient with a non-functioning pituitary adenoma. So even as general practitioners, I hope that at least the initial workup of your patient, you'll be able to do that before referring to a subspecialist. Okay? So, and then lastly, we're also going to discuss disorders of your neurohypophysis or your posterior pituitary, and that's your diabetes insipidus. And also, I will probably not be talking about hypodipsic hypernatremia anymore, but just diabetes insipidus and SIADH or your syndrome of inappropriate antidiuretic hormone. So for the first, this lesson will be divided into 6 parts. So for the first part, we will be trying to achieve objective number 2, review the anatomy and briefly review the different anterior pituitary hormones. ACPH, Cushing's disease, which is actually a pituitary disease, will be discussed in under our topic on the adrenal glands, and your TSH secreting adenoma, which is strictly speaking a pathology of the pituitary, but we will discuss this instead together with your the rest of the disorders of the thyroid gland. So I decided to start with the pituitary for the whole endocrine module because your pituitary gland is actually the master gland, no? It controls most of your other endocrine glands and even other non-traditional endocrine glands, no? Like your breast and your uterus and even your kidneys, no? So that's why it's very important to understand how the pituitary gland works in order to understand also the rest of the other glands. So just as a review, your pituitary gland is divided into your anterior and your posterior lobes. It's just a very small organ. Let me highlight, use a pointer. So it's just about 1 centimeter in diameter and also just very small at 0.5 to 1 gram in weight. But of course, this changes with physiologic changes. For example, in pregnancy, usually this becomes bigger, no, because of the increase in the demand in hormones, no, particularly prolactin. Anyway, so this is your pituitary gland, and it is located inside your sella turcica or your Turkish saddle. Okay, it looks like a saddle. Okay, and you have your anterior pituitary and your posterior pituitary. And if you look closely, your posterior pituitary is actually an extension of your hypothalamus. No, so your hypothalamus is directly connected to your is an extension also of your posterior pituitary. And your anterior pituitary is composed of your pars tuberalis, pars intermedia, and pars distalis. And it wraps around your your it wraps around your infundibular stalk, no? And your pituitary, posterior pituitary, on the other hand, is composed of your infundibular stalk and your pars nervosa, or your, it's pars nervosa because it's actually nervous tissue. Okay, it's from the neural tissue outgrowth from your hypothalamus. And you see the close relationship of your pituitary to your hypothalamus and also your optic chiasm. Your anterior pituitary or your adenohypophysis embryologically comes from your Rathke's pouch. So if you look at the if you look at the pituitary in an MRI, no, your pituitary would look like this. So this is your anterior pituitary, and this is your posterior gland with your pituitary bright spot here. And there's your optic chiasm in your hypothalamus, and this is your infundibular stalk. So in your illustration, it should look like this one. If you cut your brain and coronal section, you will see that there is your pituitary, this one, okay, this one, and there is your infundibular stalk, and that's your optic chiasm. So in this area will be your hypothalamus, and you can see the very close relationship of your pituitary gland to your optic chiasm. And other closer structures would be your cavernous sinus, your internal carotid artery, no? Okay. And your different cranial nerves in this illustration. Those yellow illustration there are your different cranial nerves. Okay. So any problems in your pituitary would have impact on the surrounding structure because this is an enclosed space in your brain. So if we divide the two, so this is your, let's go first to your anterior pituitary. So your anterior pituitary, no, this is your, your anterior pituitary is connected to your neurosecretory cells from your hypothalamus, and your neurosecretory cells sends releasing hormones into the hypothalamic hypophyseal portal circulation, and sends this releasing hormone into your anterior pituitary, either to stimulate or inhibit secretion of hormones from the anterior pituitary. Okay? So the different hormones that are secreted by your pituitary are your TSH, your ACPH, that stimulates your adrenal cortex, your FSH, and your LH, that stimulates your testes or your ovaries, your growth hormone that has effects in different parts of the body, your prolactin, no, that has effects on your mammary glands, and also lesser known would be your endorphins. But for the purposes of this session, we're just going to focus on the 5 major pituitary hormones. Now, in your posterior pituitary, you will see that the neurosecretory cells from your hypothalamus has a direct extension into your posterior pituitary. Okay? So the synthesis of the hormones actually come from your hypothalamus, and it is brought down into your posterior pituitary area of the pituitary to your neurons. Okay, so the synthesis is here, but the secretion is in the posterior pituitary. And the two major hormones that are secreted by your posterior pituitary is your oxytocin that has effects on your uterine muscles and your mammary glands, no, to produce your milk letdown reflex, and your antidiuretic hormone or your vasopressin that has actions on your kidney tubules. So this is an illustration of the general pattern or the general structure of your hypothalamic pituitary end organ axis. No? And here again, I emphasize to you that the pituitary gland is the master gland, and most of the pituitary hormones control the other endocrine glands. And as a review of your negative feedback mechanism or how the hypothalamic pituitary end organ axis works, from your hypothalamus, no, from the neuroendocrine cells of your hypothalamus, it secretes various releasing hormones acting on your anterior pituitary, and your anterior pituitary will now secrete its corresponding hormones. Those are your stimulating hormones, no? Yeah, let's call them hormone 1. And your hormone 1 will now act on your different target endocrine glands, no? Like your adrenal glands, your thyroid, your kidneys, etc. And your adrenal glands, your thyroid, what else? Even your liver, no? And your endocrine gland will now produce a secondary hormone, and the second hormone, let's say your T4, T3, your different steroid hormones, will now act on your target cells. And the hormone 2, the hormones from your endocrine glands, will now provide a negative feedback, no, to either or your end or your anterior pituitary to tell your pituitary to hold off, no, or even to increase or decrease its secretion of its hormones, no. So let's say you already have excessive hormone number 2, it will tell the anterior pituitary to stop or decrease the production of hormone number 1 so that your endocrine glands will not have overactivity and result in even more hormone number 2, no? To bring back the levels to normal homeostatic levels. Okay? So again, I cannot overemphasize to you guys that you guys should be able to understand this negative feedback mechanism in order to understand the rest of the clinical aspects of endocrinology. So these are the different pituitary axes. So again, your hypothalamic hormones regulate anterior pituitary trophic hormones that in turn determine target gland secretion. So these are your different target glands. And the peripheral hormones feed back to regulate the hypothalamic and pituitary hormones. No? So this is your hypothalamic pituitary adrenal axis. So let's go through them one by one. So your CRAs or your corticotropin releasing hormone stimulates your corticotropes in your pituitary to secrete ACPH, and your ACPH on the other hand will stimulate your adrenal glands to secrete your cortisol, and your cortisol now will have effects on cell homeostasis and function. Now we proceed with the hypothalamic pituitary thyroid gland axis, no? So your hypothalamus secretes your thyrotropin releasing hormone, or thyroid releasing hormone, to secrete and acts on the thyrotropes of your pituitary gland to secrete your TSH. And your TSH or your thyroid stimulating hormone will now act on your thyroid gland in order for increased synthesis and release of your thyroid hormones T4 and T3, which have effects on thermogenesis, protein synthesis, and many other things. It's notable that your somatostatin has an inhibitory factor on this axis. Okay, so actually somatostatin has inhibitory effects on other axes as well. So next we go to your hypothalamic pituitary gonadal axis. No? So the GnRH or your gonadotropin releasing hormones from your hypothalamus will act on the gonadotropes in your pituitary to stimulate the release of your LH and FSH. And your LH and FSH will now act on your gonads to stimulate the synthesis and release of your estradiol and progesterone from your ovaries and from your testes, your testosterone and your inhibin. And your estradiol, progesterone, testosterone, and inhibin will now send negative feedback to your pituitary to reduce its secretion of to modulate its secretion of your LH and your FSH. Now we go to we now go to your hypothalamic pituitary growth hormone axis. So your growth hormone releasing hormone is released from your hypothalamus and stimulates the somatotropes in your pituitary gland to release your growth hormone. And your growth hormone doesn't have a specific target end organ or target gland, but actually has multiple effects in different parts of the body, including your liver, your bones, your muscles, no? And even your fat cells, no? To induce linear and organ growth and development. And please note that your somatostatin also has an inhibitory effect on this axis. And then lastly, we go to your hypothalamic prolactin axis. No? This one is unique because this one does not follow your typical mechanism like in your other pituitary axis. In this axis, you have dopamine from your hypothalamus, which inhibits the tonic release of your prolactin. So normally your pituitary will just keep on secreting prolactin, but it's dopamine that has an inhibitory effect to control the release of prolactin from your pituitary. And then your prolactin now will have effects on your mammary glands to induce lactation. All right? So we'll discuss one by one the different anterior pituitary hormones. So for ACPH, LH, FSH, and TSH, I'll just briefly go over them, but we will tackle them in different sessions during your endocrine module. And then on the part 2 of this session, we're going to talk about prolactin, and then part 3, we will be talking about the growth hormone. Okay, so your adrenocorticotropic hormone or your ACPH is synthesized from the corticotrope cells of your pituitary, and the major precursor molecule will be your pro-opiomelanocortin. So pro-opiomelanocortin, it's a large molecule that is cleaved into different portions, and one of those cleavage products will be your ACPH. And as you can see, your major precursor molecule will be your pro-opiomelanocortin, and it will be broken down into your NPOC and your beta lipoprotein hormone, and then it will be further broken down into several different cleavage products, and one of which is your adrenocorticotropin hormone. Okay, so whenever your corticotropin-releasing hormone induces your corticotrope cells, it not only increases the secretion of your ACPH, but also induces the production of the entire pro-opioid melanocortin. So therefore, it's not just ACPH that increases in synthesis and secretion, but also all of these other hormones as well. So your pro-opiomelanocortin gene expression is suppressed by glucocorticoids, as in your negative feedback mechanism, and is increased by your corticotropin releasing hormone and your vasopressin. Okay? So it's not just CRH that increases the synthesis of your pro-opiomelanocortin, but also your vasopressin as well. So your adrenocorticotropic hormone has a pulsatile secretion and has a characteristic circadian rhythm that mirrors the circadian rhythm of your cortisol. So usually your ACTH rises first, and the rise in ACTH will now have effects on the circadian rhythm of your cortisol. So the peak of your ACTH is slightly earlier than the peak of your cortisol and has its peak at 6 a.m. and also has its nadir at midnight. So similarly, the nadir of cortisol, because they're directly related to one another, no, is also at midnight. So your ACPH, no, I showed you earlier the hypothalamic pituitary adrenal axis. It looks simple, but actually it's more complicated than it actually is. No, I showed you this very complex figure to show you that the axis is affected by many things, no? Particularly your stress, no? Acute exercise, acute illness, and even insulin-induced hypoglycemia. And as you can see from this figure, your physiologic stress can have impact on your brainstem catecholaminergic inputs, having impact eventually on your hypothalamus, causing changes in the corticotropin releasing hormone, because this axis is your stress response, acts whenever you have stress, no, in the environment. Physiologic stress, meaning can have impact on other hypothalamic neurons as well, that can have impact on the secretion of your corticotropin releasing hormone. Even neurogenic stress, no, like fear and let's say stress from med school or stress from COVID-19, no, that can all have impact on your CRH. And eventually, no, your stress will eventually lead to higher levels of your stress hormones, particularly your cortisol from your adrenal gland, no? And your glucocorticoids, particularly your cortisol, will now send a negative feedback to ACPH in your pituitary through suppression of your CRH and pro-opiomelanocortin gene expression and release, and therefore a reduction in your ACPH and then consequent effects on your cortisol secretion. So this is it looks simple by this axis, no? But actually it's more complex than that, okay? So next we go to your gonadotropins, your FSH and LH. So your LH and FSH have homologous structures to your TSH and your beta HCG. So I talked briefly about this in our first lesson, no? So these are glycoprotein hormones. So therefore they have a glucose residue, a carbohydrate residue, and a protein in combination with a protein molecule. And they all have a common alpha subunit and a unique beta subunit. And because of this homology, they're all closely linked to one another. And sometimes your beta HCG can act like your luteinizing hormone, or your beta HCG can have can act on your TSH receptor because of this fact, no? That they have a common alpha subunit and a unique beta subunit. Now, your gonadotropins is unique because it has a pulsatile action. Thus, the stimulation of your FSH and LH is stimulated by the pulsatile action of your GnRH, no? So your GnRH is secreted from your hypothalamus in pulses, like that, okay? And the pulsatility of your GnRH secretion is essential in order to induce your pituitary to secrete its LH and FSH. And your LH in turn is secreted by your pituitary also in pulses. So if you eliminate the pulsatility of GnRH secretion, you will not be able to induce the pituitary to secrete LH and FSH. So the pulsatility of the GnRH secretion is essential to its action on the pituitary. So, and because of that, if you have a long-acting GnRH agonist, meaning you suppress, since it's long-acting and it's an agonist, it acts like GnRH, no? So you lose the pulsatility of the GnRH secretion because it's long-acting. It will now suppress the secretion of your gonadotropins. And usually we give this to kids with precocious puberty or with men with prostate CA in order to suppress your sex steroid hormones, no? And because your sex steroid hormones are usually overactive in kids with precocious puberty. And in men with prostate CA, we want to suppress the secretion of your testosterone in order to suppress the growth of your prostate cancer. So that's how your long-acting GnRH agonist works, no? Chronic estrogen is also inhibitory on the axis. However, no, in your menstrual cycle, in your ovarian cycle, sorry, a rising estrogen in the pre-ovulatory phase sends a positive feedback to your pituitary gland in order to increase the secretion of your LH until LH surge happens. So your activin, no, from your ovaries selectively stimulates your FSH, and your inhibin selectively inhibits your FSH as well. So what are the actions of your gonadotropins? So overall, they evoke germ cell development and maturation as well as induce steroid hormone biosynthesis. Specifically, your FSH is involved, no, since it's a follicular stimulating hormone, no? Follicular stimulating hormone, it induces ovarian follicle development and ovarian estrogen production. Your LH, on the other hand, acts on your Leydig cell to induce testosterone synthesis and secretion, while your FSH in men, no, induces seminiferous, no, seminiferous tubule development and regulates spermatogenesis. So to help remind me, no, your LH acts on your Leydig cell, and your FSH acts on your seminiferous tubules, no? So LLSS, okay? So third to the last, no? Your TSH or your thyroid stimulating hormone is is secreted from your thyrotropes, no? Very small proportion of your pituitary cells, and pathologies in your thyrotropes are actually very rare. Your TRH from your hypothalamus stimulates your TSH, but also your prolactin. So that has a very big impact on your prolactin levels as well. That's why patients with severe hypothyroidism resulting in markedly elevated levels of TRH, no, can have symptoms also of hyperprolactinemia. Okay? On the other hand, your dopamine, your somatostatin, your glucocorticoids, and even your somatostatin, no, can suppress your TSH. So that's the end of part 1. So let me know if you have any questions. You can type them up in MS Teams or you can ask them during our class discussion later on. Okay?